So the lecture that has been given to me is what's new regarding imaging of liver tumor. Indeed, for that topic and that lecture, I don't have any conflict of interest. So the outline I have chosen for you is, first of all, to touch a bit of what's new regarding the characterization and subtyping of hepatocellular adenomas. And then we will go more deeply in liver malignancies, HCC and liver metastases, and we will look at new aspects regarding screening, diagnosis, and staging. And then we will end up with a few words regarding quantitative imaging. So let's start with the hepatocellular adenoma. You know very well this classification that has been brought by Jessica Zussman and her team in the 2010, which defined, beside the unclassified, three major subtypes, the HNF1 alpha, the inflammatory hepatocellular adenoma, both of them comprising 80% of hepatocellular adenoma, and then the beta-catenin exon 3. Interestingly, we have been working at the imaging features after this genotype-phenotype classification, and the Bordeaux group and also our group have been able to really find imaging features that are highly sensitive and highly specific for the subtype. I would like to show the first one, which is HNF1 alpha hepatocellular adenoma, and by using only one imaging finding, which is here, the marked signal drop on opposed phased image that reflects the content of fat within the lesion is highly characteristic of this hepatocellular adenoma. In the same time, we're able also to define imaging features of inflammatory hepatocellular adenoma here. For this one, we combine the strong hypersignal on T2 as well as persistent enhancement on delayed images. And you can see here the presence of the fat vacuoles within the cytoplasm of the hepatocellular adenomas, and here the dedicated immunostaining. But since that time, new subtypes have been also defined and found by the group of Jessica and also including Jean Charnot with the beta-catenin exon 7, 8 and the sonic hedgehog. And we are just, starting to define and to correlate this histopathologic classification with also other imaging finding. And this is an example in a woman with a high BMI with the liver steatosis. We have not found any specific imaging findings related to the inflammatory or the HNF1 alpha subtypes. On the contrary, we found liver steatosis plus strong hypersignal on T1 reflecting the content and the presence of macroscopic hemorrhage. So this is certainly an interesting finding, especially in obese patients or patients with liver steatosis. It was further confirmed by the negativity of the classical immunostaining and the positivity of the PGDS. So this is just a preliminary finding that has to be confirmed with indeed more cases. Another thing that is, I think, quite interesting is the beta-catenin exon 3. You know that this subtype is associated with a higher risk of malignant transformation, having cellular atypias, and so far no one has really found specific imaging findings. On the other hand, we use more and more hepatobiliary contrast agents with MR that are not only intravascular and extracellular, but they enter into the hepatocyte through transporters, mostly OATP. How do most of the hepatocellular behave? This is the pre-contrast T1, and this is the hepatobiliary phase using either Primovist or Multihance. And you can see that 90% of the hepatocellular adenomas are hypointense on hepatobiliary phase, lacking the transporters. But we know also that in a small subset of hepatocellular adenomas, some of them will uptake the contrast during the hepatobiliary phase. This is pre and this is the hepatobiliary phase. So as other groups, we have been looking at these different hepatocellular adenoma, and if we see here uptake, positive uptake during the hepatobiliary phase, this actually seems to be very specific for beta-catenin exon 3. So we think that this positive contrast uptake might be a good indicator of the presence of beta-catenin exon 3 activation, and this is something that could really change patient management. Now moving on, screening. And we will start with the hepatocellular adenoma. You know, this comes from the last EASL guidelines, and this is common in all guidelines dealing with HCC. Surveillance should be performed in all high-risk populations and using abdominal ultrasound every 6 months. And this is an example of the benefit of a surveillance program, where we can see here a small-sized lesion that turned out to be HCC. However, if we look at the diagnostic performance of ultrasound, it is rather disappointing. This is a recent meta-analysis showing that, yes, sensitivity to depict HCC is more than 80%, but if we look at the sensitivity to depict small-sized HCC, so early-stage HCC that are amenable to a curative surgery, here clearly the sensitivity drops down, and we cannot say that we are really happy with that. So how can we do better? So there are many ideas regarding imaging to perform CT, but we are not going to perform regular CT because with the radiation issues. So why not doing MR? Because MR is very interesting imaging modality, and we know that MR is more sensitive than CT. But today, it's difficult, it's not really available, it's an expensive imaging modality, and it takes long. So why not doing fast MR, so-called abbreviated MR? So these these are preliminary, but very interesting. So actually, there are two scenarios how to do well and fast. We take the most interesting sequences. Here, this is a T2. Here, this is a diffusion, and you can see a small lesion that is HCC. And this is the hepatobiliary phase at 20 minutes. And to do this exam fast, we actually inject the contrast agent outside the MR room, and 20 minutes later, the patient goes in. And within 10 minutes, we perform 3 sequences that are very sensitive to depict any lesion. So the other scenario would be, okay, we don't do these sequences, we just do pre-contrast, arterial phase, portal venous phase. So this is very interesting, and I think there is a lot of excitation regarding that with different results. Briefly, if we take the first scenario, that's not bad, but these are really preliminary results. We have to take them cautiously. They are comparable, just a bit less sensitive than the contrast enhanced. And the other scenario seems also to be interesting. Actually, there are not much change between this fast contrast enhanced set with extracellular versus full MR. So what should we remember about the screening possibly with abbreviated MR? I think it will play a very important role in the future, but there are questions. Should we perform this MR as a first-line surveillance tool in all patients? Only in patients in whom ultrasound is difficult, and we know that we can find out these patients, or in very high-risk patients. This is probably the most interesting options, and we will try to work in the future years solving these questions. So based on this possible change in the screening, can we do the same with the liver metastasis? Actually, we have less data, but also growing interest. This is just one retrospective study that has simulated an abbreviated MR using the hepatobiliary contrast agents, so the Primovist, and shows that this abbreviated MR compares very well with a full MR with a very high sensitivity and area under the curve. Indeed, the rule is acquisition time less than 10 minutes in and out. should we really extrapolate that to all patients being at risk of liver metastasis? Certainly not, because we know that CT and contrast-enhanced CT has a high negative predictive value, but probably it will be interesting to perform this abbreviated MR in patients having a high likelihood of liver metastasis and in patients requiring complex surgery of the primary cancer. And there is really a very good example with strong evidence now with patients having resectable pancreatic adenocarcinoma in whom MR followed after, performed after a negative CT is able to show liver metastasis in 15 to 20% of the cases. So certainly not in all patients, but probably in this very dedicated patient population. What's new regarding the diagnosis of HCC? You are certainly aware of the algorithm of the last EASL guidelines released in 2018. I just want to stress three things that are really different from the previous one. If you do remember the first one, the algorithm was made starting with a mass or a nodule seen on ultrasound. But we see more and more patients having CT or having MR because they had a history of HCC or for any other reason. So I think we, and this is important, can apply the algorithm with any imaging showing a liver nodule. Second, we have kept the stratification less than 1 centimeter, where the likelihood of having HCC is really low, and more than 1 centimeter. Indeed, we should perform contrast-enhanced imaging in patients having suprasentimetric nodules. Which imaging? Contrast-enhanced CT or MR. But here we have added something, MR with any contrast agent. And you know that there is still a huge debate in the literature. Should we start with the classical contrast agent, so-called extracellular, or should we do what most of the Eastern guideline proposed as a first line? Should we use the gadoxetic acid, so-called Primavist, which is the hepatobiliary agent? So what are the advantages and drawbacks? If we stick on the classical extracellular agent, we have shown, and it will be published recently with a large multicentric French study, that we get a better arterial phase, a better visualization of washout, and indeed a better diagnostic performance with the extracellular agent. Okay, so what are the advantages of the Primavist and gadoxetic acid? Actually, it's very interesting to depict any nodule, not only the HCC, but also atypical nodules, some of them that could evolve into HCC. And also, it is interesting to increase the detection of additional HCCs in patients considered as having a single one. So if we want to summarize, and I think the first one, if we stick here, is really interesting for the diagnosis, where the second contrast agent is certainly better for the staging. We are not probably completely ready to have different indications for MR, but I think this is important to point out. The third thing which is really different from the previous guidelines is when first contrast-enhanced imaging is negative, then we should perform another one. If we have started with CT, we can do an MR, or vice versa. But we have also introduced the contrast-enhanced ultrasound. I should say we have reintroduced, because it was in 2005 guidelines, was retrieved in 2012, but now it is back because imaging criteria of HCC using contrast-enhanced ultrasound are much better defined, so with a high specificity. And the last thing I would like to stress with the diagnosis of HCC is the LIRADS. So it comes from the United States, from the American College of Radiology. So LIRADS is a classification based on imaging finding that is applied on inpatients at risk of HCC. Briefly, the classifications goes from LIRADS 1, 2, which favors indeed benignity, to LIRADS 5, which is very likely to be HCC. So indeed here we have imaging findings of a small hemangioma in a patient with a cirrhosis. And here you can see and you can recognize the typical features of HCC: hyperenhancement on arterial phase and washout. Actually, we don't need LIRADS to differentiate very benign from malignant. Why LIRAD is interesting? Because it introduces LIRAD 3, LIRAD 4, which indeed are lesions that do not meet imaging criteria for HCC. For instance, LIRAD 3 here, hyperenhancement, but no washout. Here, hyperenhancement and ancillary findings, hyperintensity on diffusion. Okay. Plus, LIRADS M. M for malignant, suggesting that in patients with cirrhosis, we may see imaging findings that suggest malignant that are not HCC, such as cholangiocarcinoma or liver mets, by showing target or targetoid appearance. And why is LIRAD interesting? Because it gives you the average probability of imaging features for HCC. And indeed, we are not surprised by 0 here and nearly 100%. But what is interesting for patient management is having a patient with a LIRAD 3 nodule. I know that the average probability of this patient for HCC is just 30%. So it may change the patient management. Staging liver malignancy now. Okay. So there are common principles with the staging with imaging. We have to look at the intrahepatic staging and the extrahepatic staging. Within the liver, how many tumors, where are they, unilobar, bilobar, the relationship with major vessels and the vessel involvement. Okay. And here, indeed, we should not consider in the same way if we deal with HCC or if we deal with liver metastasis. Vessel involvement is very important for HCC and cholangiocarcinoma. For extrahepatic, very classical, we will look for nodes, we will look for peritoneal carcinomatosis and distant metastasis. And again, lymphadenopathy, distant metastases are much more important and much more common in patients with cholangiocarcinoma and liver mets. I want to stress that for staging, it is especially important if we deal with the resection or locoregional treatment. So then I just want to stress the intrahepatic staging. And if we consider a patient with HCC or a patient with liver metastasis, I have just one message for you, a very simple one. MRI is the imaging modality for staging. Let's see an example of a small HCC here. This is the arterial phase, the portal venous phase, and this is the hepatobiliary. The patients had a resection, and this is the specimen with the tumor. Do we see something else? Yes. We see very small here that are satellite nodules that were actually seen on the preoperative MR and spatially on the hepatobiliary phase. And this is very important because by seeing that, we change the indications from tumor ablations to tumor resections with resection of a much larger liver volume. So here, MR is basically superior to CT for the diagnosis, and MR, and spatially using hepatobiliary contrast agent, is much more superior to CT for intrahepatic staging. And it is the same with the liver metastasis. We know for years that MR is the preferred first-line modality to stage meaning in patients considered resectable, which exam should we perform just next or prior to the surgery, MRI. How should we do that? With a very recent technique using diffusion and using, again, hepatobiliary sequence because both are very sensitive. And I would like to share with you this example. This is a patient with suspected liver metastasis, but on CT and MR, we could only see a small lesion that is a small cyst. And now, if we look at the diffusion, weighted imaging, here, and the hepatobiliary phase, we were able to diagnose additional lesions. Last, I just want to touch this issue with you. We use every day in your practice imaging biomarkers, quantitative biomarkers such as liver stiffness, fat fraction, liver volume, and so on. So we do one exam, one acquisition, one modality, and then we get one biomarker. But things are changing with the world and the era of omics and the radiomics. We now are interested in finding many data in a region of interest or a volume of interest. So because the idea behind is in these medical images, there is a lot of information which is not visible to the naked eye. And that reflects underlying pathophysiology. And just one example, because this is really the starting point, we see paper now dealing with radiomics. Radiomics by itself is interesting, but the diagnostic performance is not sufficiently high. But radiomics, with the help of the AI tool, artificial intelligence tool, is really changing the paradigm. Because here we will put deep learning, machine learning model, and we will predict whether the patient has an indication to taste because we have good predictors of tumor response or the patient has poor predictors. And this is really changing. But if we want to be ambitious, we will not stick only on radiology. We will combine all information dealing with images. So imaging, nuclear medicine, pathology, in order to have a multi-scale, multi-parametric imaging approach, and this is a project that we have submitted and that was recently accepted, the FHU with Valérie Paradis, in order to improve tumor characterization and disease monitoring, helping in prognostication, and really to get a virtual imaging biopsy by adding a piece of information at all these different levels. And with that, I would like to conclude. So I hope that you are convinced that liver imaging is improving in many ways, diagnosis and characterization. There are new and very interesting questions regarding screening of liver malignancy, HCC, liver met, and also quantitative imaging benefits from mathematics and artificial intelligence. Thank you very much.